Teachers and dear friends, the topic for discussion is free flaps in head and neck reconstruction. So this topic will be dealt in two classes. So this class is an overview on the free flaps and how it is reconstructing the head and neck defects. When we look into the treatment of head and neck cancers, there are so many innovations in the surgical treatments as well as the non-surgical component, and the quality of life and impact of treatments on the fundamental aspects of the patient is more important, and that is placed at the center of attention. That is the functional and the aesthetic outcomes. The surgical techniques which are developed in the recent years are with the aim of restoring anatomical integrity, function, and aesthetics. Free tissue transfer is a widely accepted reconstruction option within the head and neck, and this has led to better functional and aesthetic results. So, when we look into the advantages of the free flaps, it is always intertwined with the development of the modern microsurgery. So, without the microsurgery, the free flap would not be reached at this level. So, the three pillars, the fundamental pillars of microsurgery are based on these three basic pillars, that is the microvascular anastomosis, the second one is anticoagulation, and three is the visual magnification. So, these are the basic pillars that flourished the microsurgery and thereby made advances in the free tissue transfer in the present era. So, what is free tissue transfer? Free tissue transfer refers to the isolation of tissues, fascia, skin, fat, muscle, nerve, and bone, either individually or in combination with a vascular pedicle, and this is being transferred to a new location using the microvascular surgical techniques, and we are revascularizing the recipient area in a permanent way. So the three thing is we are transferring different types of tissues with a supporting vascular supply, and this is transferred to a recipient area, and that is revascularizing that tissues in a permanent fashion. It relies entirely on the anastomosis of the feeding artery and the draining vein to blood vessels in the head and neck, and this is very important for the tissue survival. So, the factors largely responsible for the rapid growth of the free tissue transfer was the advances in the operative microscopes, instrumentation and microsuture manufacturing technology, the understanding of the surgical anatomy, and formalized training opportunities and unparalleled success rates for this free tissue transfer. So, these are the factors which made the rapid growth in the spread of free tissue transfer in the present era.
What happened?
So there is some problem with the screen, sir. 1 minute, sir. 1 minute.
There is a message that is coming mentioning you to move the screen away or something like that.
Yeah, yes, sir. Yes, sir. That is a problem. what are the advantages of free tissue transfer in head and neck reconstruction? It is the versatility in tissue that we can transfer skin, muscle, bone, and nerves. Versatility in orientation. There is no limitations on flap reach as with vertical flaps. There is adequate restoration of shape, function, and sensation. A single operation for complex reconstruction. Multiple potential donor sites are available. Simultaneous resection and flap harvest is possible. The donor site is out of the treatment area, and there are extensive amounts of tissue available for large or massive defects, and the most of these tissues will post-operative radiation tolerance. There is independent blood supply for compromised tissue beds, improved function and cosmesis. We can rehabilitate the patient. Even dental rehabilitation is possible, and high success rates, more than 90%, including for bony reconstruction, and it is the only available option for some patients in salvage setting. So these are the main advantages of a free tissue transfer. The disadvantages, even though we have lot of advantages, there are disadvantages too. And the most important disadvantage with the free tissue transfer in head and neck area or in any part of the body is the increased technical difficulty. That is, we need additional training. Two surgical teams are required for the resection and the reconstruction, including the surgeons and the nurses. There is expensive instrumentation is needed for the surgery, longer operation times, more intensive post-operative management, and there is a chance of donor site morbidity. The defects or situations that commonly require the free tissue transfer in head and neck is the composite defects of the oral cavity, three layer or through and through defects of the oral cavity, near or near total pharyngoesophageal defects, extensive skull base defects, extensive scalp defects, massive defects not readily addressed with other technique of other regional or local flaps, lack of other reconstructive options, failures or patient limitations, and salvage surgery for chemoradiation failure. These are the situations or the defects that commonly require a free tissue transfer. So when we look into the donor site option, there are more than 40 donor sites for free tissue transfer. And a basic classification which I have put for the simplifying the classification of flaps used for the reconstruction as a free tissue transfer, we can classify it into fasciocutaneous flaps, osteocutaneous flaps, visceral flaps, and muscle or myocutaneous flaps. In the fasciocutaneous flap, the most common fasciocutaneous flaps are radial forearm, lateral flap, lateral thigh, anterolateral thigh, scapula, parascapula, and temporoparietal. And of the osteocutaneous flaps, fibula, radius, scapula, and iliac crest. Visceral flaps we usually come across in the head and neck area is the jejunum and the gastroomental flap. And some myocutaneous flaps are also used in the head and neck area. Is mainly the main ones are rectus abdominis, latissimus dorsi, and gracilis. So when we made up a mind to reconstruct a defect with free flap, the important consideration that will influence the flap selection is the skin and the soft tissue oleum. The how much is the defect, how much is the skin defect, how much is the soft tissue defect, and the bulk and the color match. Then we have to look into the pedicle length and the vessel caliber, whether we will be able to innervate that flap, that is innovation capacity of that donor flap, the quality, the quantity, and availability of the bone if you are using a bone flap reconstruction, and the donor site location to allow concurrent resection and harvest. And we have to also look into the donor site morbidity, mainly the dysfunction and the cosmetic deformity. So with this introduction, I am going to the individual flaps, that is a fasciocutaneous flaps first, and a short in word about fasciocutaneous flap. What fasciocutaneous flap provide is a segment of skin and subcutaneous adipose tissue of variable size and thickness. The pliability allows for precise anatomic restoration. The important thing of the fasciocutaneous flaps, it is very much pliable, and that will allows for precise anatomic restoration. The adipose tissue, which is within the revascularized flaps, does not atrophy. So, this will also allow for precise and permanent restoration of the condor deformities. And this is basically based on one or more pedicles to fascia that runs in the intermuscular septa. When we look into the classification of the fasciocutaneous flap, Cormack and Lamberti, it classified the fasciocutaneous flaps into four major types, differentiated by the origin of circulation. So, the first one is a type A. Type A is a pedicled flap based on several vessels entering the base of the flap and following the long axis of the flap. And type B is a pedicled or a free flap based on a single perforator vessel at the level of the deep fascia. And type C is a pedicle or a free flap based on multiple small perforators originating from deep artery and reaching the fascia along a septum between the muscle. And type D is a fasciocutaneous flap that is harvested, that is within the adjacent muscle or bone with the same feeding artery. So this is the classification put forward by Cormack and Lamberti regarding the fasciocutaneous flaps. Coming to the individual fasciocutaneous flaps, radial forearm flap. This flap was first introduced in 1981 by Ang et al. And this is called as Chinese flap because this Ang et al. Has published about 61 cases of radial forearm, and it was popularized in the Chinese literature, and this was accepted by the world, and that is why it has been called as a Chinese flap. And the use of radial forearm flap in intraoral reconstruction was popularized by Soutar. The importance of radial forearm flap is that it provides a large amount of thin, pliable skin, and this flap is based on the radial artery and either the cephalic vein or the venae competens, and this may be transferred as a composite flap also. That is the importance of radial forearm flap. Apart from as a fasciocutaneous flap, we can make it a composite flap if we incorporate the vascularized bone, a tendon, the brachioradialis muscle, nerve or sensory nerves. So the bone which we usually take is the radius. So the advantages of radial forearm flappers, it provides a large amount of relatively thin hairless skin, and it can be folded on itself to conform to nearly any mucosal or cutaneous defects. Second one is it has got a long vascular pedicle, and the vessel wall size is up to of large size, that is 2 to 2.5 millimeter. And the length of the pedicle is about 20 centimeter, facilitating dissection and revascularization. The sensation can be restored to the skin paddle by incorporation of the medial or lateral antebrachial cutaneous nerves, and it permits simultaneous two-team harvest and dissection under tourniquet control. It can also be said, as I earlier said, it can be also be used as an osteocutaneous flap. That is, we can take about 10 to 12 centimeter long bone encompassing 40% circumference of the radius and can be harvested with the skin paddle. So the radial forearm flap can be used as a composite flap also, and we incorporate a vascularized bone, tendon or a bit of skin nerve also. So this is the osteocutaneous flap where we are taking a 10 to 12 length of radius and 40% circumference of the radius bone. And the segment of radius is limited by proximally by the insertion of the pronator teres and distally by the insertion of brachioradialis. So the length we can accommodate in this flap is 10 to 12 centimeter, and the circumference is 40%. The disadvantages of radial forearm flap is it is, unless extremely small, the donor site always needs a skin grafting. We cannot close it primarily. And the most devastating complication is the vascular compromise of the hand. So a preoperative allenstosis is very important before going for a radial forearm flap. Even though if we are getting a normal Allen's test, sometimes there is insufficient flow to the neck hand. And the fourth problem is the numbness of the hand that may be due to the trauma to the superficial radial nerve branches and transection of antebrachial nerves. This, the infective disadvantage is the suppurative tenosynovitis of the tendons exposed, and we can come across sometimes poor take of the skin graft, and the forearm tendons may be exposed. And the most important cause for poor uptake of the skin graft is the shearing forces of underlying muscle due to inadequate mobilization. And second cause is failure to preserve the paratendon over the flexor tendons. So if you don't look into these two factors, there is a high chance of poor take of the skin graft and there is exposure of the forearm tendons. And if we are using this radial forearm flap as a composite or a osteocutaneous flap for a mandibular or a maxillary reconstruction, the limited bone stock restricts the potential for functional dental restoration. So, nutshell, what are the uses of radial forearm flap in head and neck area? It is the free tissue transfer of choice or resurfacing of the oral cavity and oropharyngeal defects. It is also used for reconstruction of hypopharynx and cervical esophagus, that is a function aerodynamic funnel for pharyngoesophageal defect. And it can also be used to resurface the scalp and a variety of face defects, including the cheek, nose, chin, and forehead. We can also make this radial forearm flap a sensate flap. Okay, so how we can make the sensate flap is using this lateral cutaneous antebrachial lateral cutaneous antebrachial nerve, that is the lateral cutaneous antebrachial nerve. If we take this nerve along with the flap, it can be anastomosed with the proximal stump of the lingual nerve, or more rarely with a branch of the cervical plexus, so that by anastomosing this lateral cutaneous antebrachial nerve to either to the lingual nerve or to this cervical plexus branch, we can make this radial forearm flap a sensate flap too. One thing to mention is, okay, I'm sorry for that inconvenience. If we are using this radial forearm flap for reconstructing the hypopharynx or in the deep part of the oropharynx, the monitoring of the flap will be a difficult part. So, in such a situation, there is one way to tackle this. This is one design where we make it two skin paddles, and this distal paddle is for resurfacing the mucosal defect, and this proximal one is exteriorized in the neck. So, this area can be monitored to look into the viability of the flap, and this is mainly uh, done when we are reconstructing the flap for reconstructing the hypopharynx or the deep oropharynx. A word about the harvest technique in the radial forearm flap. This is a standard technique. I'm just going through. So this is the standard design of the radial forearm flap, the first one. Next, we are putting an incision of the fascia and we are exposing the flexor carpi ulnaris, distal skin incision and a subfacial dissection. This is a subfacial dissection. We usually do a subfacial dissection. There is a suprafacial dissection too, where we almost preserve the suprafascia. But this is a subfacial dissection which I am telling to you. This is a distal skin incision, subfacial dissection, and then we will expose the flexor carpi radialis tendon. Then we have to identify the radial vessels and the superficial radial nerve at the distal flap margin, ligation of the radial vessels at the distal flap border, And we will carry on with the radial skin incision. And the pedicle, dissecting the pedicle, is done along the brachioradialis muscle. And after completing the subfacial flap elevation, the skin is incised at the proximal flap margin and baby incision for exposure of the pedicle. After exposure of the additional superficial vein, we can either include vena competens or we can include the cephalic vein. The entire vascular pedicle is exposed, and after complete dissection of the pedicle, this is how we get the flap. And this residual attachments to the flap is separated, and this is the end result. The flap is raised completely with a superficial vein and an artery. So this is two techniques which I have already told. There is a subfacial, this is a facial one, and this is a suprafacial harvesting technique. So with this, I am coming to the second flap, that is a lateral arm flap. Song et al. Introduced this flap in 1982. This is most frequently a fasciocutaneous flap. It can also be raised as a monocortical segment of vascularized humerus. So it can also be made a composite flap when we take a part of the humerus, that is the measurement can go up to 10 centimeter, with the triceps tendon and two nerves, that is the posterior cutaneous nerve of arm and posterior cutaneous nerve of forearm. And usually the posterior cutaneous nerve of arm is used for sensation, for the sensory supply, and the posterior cutaneous nerve of forearm is used as the vascularized nerve graft. So the main blood supply to this lateral flap is the anterior collateral. And there are two branches for the profunda brachii artery, anterior collateral branch and a posterior collateral artery. So the main supply to this lateral flap is the posterior radial collateral artery. And this is one article published by Ribet et al. On to the anatomic study of the lateral arm flap. And regarding the maximum dimension of the cutaneous flap of lateral arm flap, it has not been determined so far. So there are so many controversies. Some people say we can take a lot, we can harvest a wide area of forearm, lateral arm, but some people say it is not practically possible. But as per the Rivet et al. Zone of security, what he said is 12 centimeter proximal to the lateral epicondyle. So this is the lateral epicondyle, 12 centimeter proximal to the lateral epicondyle, and included 1/3 of the circumference of the arm. This area, this B, this the second picture, we can see this is the zone of security. So whenever we harvest a lateral arm flap, include or incorporate this zone of security to ensure vascularity and a successful reconstruction. And when we look into the further aspects of the lateral arm flap, Katasarus et al., he did a dye injection studies to look into the cutaneous paddle, how much we can take the cutaneous paddle. And as per his study, it ranges from 8 into 10 centimeter to 14 into 15 centimeter. The width of the harvested skin is limited to 6 to 8 centimeter, or 1/3 of the arm circumference. And if we go ahead of this, then the primary closure to that area will be difficult. And in the head and neck region, it is most commonly, the lateral arm flap is most commonly used for facial and intraoral reconstruction. It has got intermediate thickness, that is relative to the thin radial forearm flap, and thicker anterolateral thigh flap and the scapular system of flaps. So the thickness of the lateral flap lies between the radial forearm flap and the anterolateral thigh flap or the scapular system of flaps. The advantages of lateral flap is the harvesting of the posterior radial collateral artery, like the radial artery, it doesn't possess risk for lymph ischemia. And the donor side rarely requires a skin graft. Most of the time, we can go for a primary closure. And this flap can be harvested with the patient in the supine position, allowing a simultaneous two-team approach. The disadvantages of lateral arm flap is there will be a linear scar on the lateral aspect of the arm, anesthesia of the forearm as a result of the transection to the posterior cutaneous nerve of the forearm, and dissection of the vascular pedicle of the lateral arm of the lateral flap is more tedious than that for the radial forearm or the scapula fascia cutaneous flap. Technically, the dissection is difficult. And last one is the average length of pedicle is 4 to 8 centimeters. So the pedicle length is comparatively less compared to the radial forearm flap, and it is one limitation for its use in certain head and neck defects. Coming to the third fascia cutaneous flap, that is the most commonly important flap which we use in the head and neck area, that is the anterolateral thigh flap or the ALT flap. This was first described by Song et al. In 1984, and it was popularized for head and neck reconstruction by Koshima and Kimata in 1990s. It was harvested from the anterior thigh in the area overlying the septum between the rectus femoris muscle and the vastus lateralis muscle. So it is harvested from the anterior thigh overlying the in the area overlying the septum between the rectus femoris muscle and the vastus lateralis muscle, and this is based on the musculocutaneous perforators of the lateral circumflex femoral artery, and we will get a vascular pedicle of up to 16 centimeter length with a large diameter vessels. And this is the landmark. This is the anterior superior iliac spine, and this is the lateral border of the patella. The skin paddle is centered on a line that is drawn from anterior superior iliac spine to the lateral border of the patella. And when we look into the anterolateral thigh flap, I said it is based on the perforators. There are three types of cutaneous perforators for anterolateral thigh flap. Type 1 is cutaneous perforators arise from the, there are three branches for the branches profunda femoral artery, that is the ascending branch, transverse branch, and the this one descending branch, the lateral circumflex femoral artery of the profunda femoral artery. So of this, in the type 1, the perforators arising from the descending branch of the lateral circumflex femoral artery. In type 2, the cutaneous, that is the commonest type. In type 2, the cutaneous perforators arise from the transverse branch of the lateral circumflex femoral artery, and it occurs in 5% to 10%. And in type 3, the cutaneous perforators arise directly from the profunda femoris artery, and it occurs in 5 to 10%. So the perforators are very important when we are harvesting the anterolateral thigh flap. And uh, when we are harvesting, even we can use the Doppler help to pick or the spot the perforator. The other aspect is how far we can take, how much territory of anterolateral thigh flap we can harvest. It can up to 20 centimeter in width, that is we can take a width of 20 centimeter and about 30 centimeter in length. So it is available for transfer based on the cutaneous branches of the lateral circumflex femoral artery. So the maximum flap width, so the thing is we can get a good amount of flap, but what happens to the donor area, whether is it possible for primary wound closure, that depends on the patient's stature, the body habitus, and the skin laxity. And when we look into the anterolateral thigh flap, the upper thigh is shows more skin laxity than the distal thigh, so it permits the harvest of a wider flap in the proximal thigh while still achieving primary wound closure. So how we can assess how much whether we can go for a primary closure for the donor area, we have to by just pinching the skin of the thigh flap donor area between the thumb and fingers, and the maximum flap width that allows for primary closure is about 8 to 10 centimeter in most of the patients. And here also we can make the flap a sensate flap by sensory reinnervation using the lateral femoral cutaneous nerve. The advantages of anterolateral thigh flap is we get a large area of skin for harvest. It is a really straightforward dissection. Dissection is not that tedious compared to the lateral forearm. Minimal donor site morbidity allows for an easy two-team approach, and no special positioning is needed. And there are some disadvantages. There is excessive flap thickness in obese patient. The thickness is comparatively high, and it is more. It will be definitely more in patients with high BMI. And there is potential for hair bearing skin in men. And In 60% of the patient, we need to take a cuff of vastus lateralis muscle. Why? Because the skin is supplied by perforators that traverse a muscle rather than the pure septocutaneous route. So, in such a situation, when it perforates the muscle, then we have to take a cuff of vastus lateralis, and that happens in about 60% of the patients. So, coming to the uses of anterolateral thigh flap, it is mainly for the reconstruction of oral cavity with the defects of the tongue, buccal mucosa, palate, and lips. The problem is the thick, bulky ALT flap is mainly used when we are having a total or a near total glossectomy. For a hemiglossectomy, this thick flap we have to rethin. We have to thin the flap and then we have to use it. So in hemiglossectomy, we always prefer a radial forearm flap. But if you want to reconstruct a total or a near total glossectomy, the choice goes to anterolateral thigh flap. And in situations when there is extensive lip resection causing oral defect, incompetence, we can use ALT free plus with vascularized fascia lata, and that will help a static suspension for the reconstructed lip position. And of course, for the through and through defects of the buccal mucosa, independent skin paddles, either by centering each skin paddle on the independent cutaneous perforators, can be used or by depithelizing the portion of the flap that is located between the internal and external skin paddles. So since it has got a wide area, we can even use it for through and through defects of the oral cavity, including the buccal mucosa. Even in situations of pharyngoesophageal reconstruction, we can use anterolateral thigh flap. Uh, we can tube the flap. The thickness is a problem. Here also, some days we need thinning of the anterolateral thigh flap. And it is also a flap of choice for soft tissue defects of the skull base, midface, and scalp. The last fasciocutaneous flap is the temporoparietal facial flap. When we look into the temporoparietal facial flap, we have to look into three things. That is the deepest plane. The deepest plane is the temporalis muscle. This is supplied by the anterior and the posterior deep temporal arteries. The temporalis muscular fascia is supplied by the middle temporal artery, and the temporoparietal fascia is mainly supplied by the superficial temporal artery and the vein. The temporoparietal fascia is actually a continuation of this mass, and it is going and continuous with the gallia aponeurotica. So it is based upon the superficial temporal artery and vein. It is a very thin flap, highly vascular, exhibits a high degree of pliability and flexibility. It allows to drape around grafts and into cavities, maintaining its durability. It is resistant to infection when transferred into infected or irradiated tissue beds. In head and neck reconstruction, it was most commonly used as a pedicled flap. But if we have a limited arc of rotation, or if the defect is located at distant side, we can use the temporoparietal flap as a free flap. The advantage of a well concealed donor site in the hair bearing scalp is one advantage of temporoparietal facial flap. It can be transferred independently or in combination with the skin and calvarial bone, again a composite bone. It may be harvested with a dimension in the range of 14 into 17 centimeter with a thickness of 2 to 4 millimeter. Sometimes we can use two layers of vascularized fascia. If we need two layers of vascularized fascia, we can use temporoparietal fascia can be harvested along with the temporalis muscular fascia. So this is a picture showing a temporoparietal fascia and a temporalis muscular fascia. We can harvest both these fascia simultaneously and can use in situation where we need a two layer of vascularized fascia. The uses of temporoparietal fascia are useful in managing problem cavities and for coverage of cartilage graft as in norcal and in the larynx. That is in tracheomalacia and all we can line this cartilage. It may be used in the face, hand, lower extremity when a skin graft is preferable to a bulky flap, but where a suitable recipient bed is lacking. In radiated temporal bone and orbital cavities, we can use this temporoparietal facial flap, and correcting the condor defects of the midface and orbital region. And also in craniofacial defects, we can use in conjunction with the outer calvarial bone. With this, coming to the second entity, that is a myocutaneous free flaps. Myocutaneous free flaps are versatile reconstructive tool as they produce bulky tissue with reliable vascularity to the overlying skin. It has got a greater versatility in design, and the three-dimensional freedom of maneuverability is there for flap insetting. It is more appropriate for extensive soft tissue defects of the tongue, even in scalp, skull base, and paranasal sinuses. It can be re-innervated for reanimation of the paralyzed face, that is mainly the Gracilius muscle. And the most commonly used musculocutaneous flaps are the rectus abdominis, gracilis, and the latissimus dorsi. Coming to the rectus abdominis flap, it is one of the most versatile tissue transfers in the head and neck reconstruction, used frequently when bulky soft tissue is required for reconstruction, especially after total glossectomy. The most important use of it is in the skull base reconstruction, especially in irradiated patient, to prevent a CS of leak and an ascending infection, and to provide vascularity to the free calvarial bone graft. And the most important advantages of rectus abdominis muscle is it is the primary vascular pedicle, that is a deep inferior epigastric artery and the vein. It is quite a long pedicle and it is of enough caliber. It is a large caliber, and it can be harvested when the patient is in the supine position, allowing a two-team approach. A large amount of tissue can be harvested and primary closure of the donor defect can be still be achieved. The rich vascularity of the abdominal wall allows flexibility in the design of the paddles. The skin paddle can be oriented in transverse, vertical, or an oblique direction. Donor morbidity is very minimal, and the durable anterior rectal face sheath and tendinous inscription facilitate placement of sutures during the insetting of the flap. So it allows a watertight closure, and it also obliterate dead space. And this is very important when we are reconstructing in the oral cavity and also in the skull base. The disadvantages of rectus abdominis flap is it is excessively bulky flap, especially in obese patients, and this can be corrected by subsequent debulking procedures or by intraoperative modification of the flaps design. The other problem is necrosis of the fatty tissue, because this flap is quite thick. Because of the critical blood supply and increased flap weight, the fatty tissue can go for necrosis. And as per the studies, flaps weighing more than 1000 gram, having only one suitable perforator, the fat necrosis can occur in up to 45%. So if the flap is quite heavy and if there is only one perforator, this fat can go for necrosis. Fat raising can be associated with the herniation of the anterior abdominal wall if the rectus sheath has not been closed properly. The second myocutaneous flap is the Gracilius flap. It is the first musculocutaneous flap to be transferred by microvascular technique. This is proposed or introduced by Harry et al. In 1976, and it is the main flap used for dynamic facial reanimation. The why it is being used for facial reanimation is because the muscle's individual fascicular territories allows the use of smaller muscle units for restoration of specific facial movements. So this is a picture showing this is the Gracilius muscle, and this is how the Gracilius muscle, this is the supply to the Gracilius muscle, that is from the profunda femoris. The adductor branch is supplying the Gracilius muscle, and the primary use is it for facial reanimation. Then the other thing is we can re-innervate also because of his contractile activity. So we can see that the in this picture, this is the obturator nerve, and this nerve is anastomosed to the mesenteric branch of the trigeminal. So by this, or we can even cross anastomosed to the facial nerve via a sural bridge also. The problem with the Gracilius flap is the skin paddle vascularity is less predictable than any other musculocutaneous flap. It is more often used as a muscle-only flap for dynamic facial reconstruction. The last myocutaneous flap is latissimus dorsi flap, and it is harvested as a muscle or a myocutaneous flap based on the subscapular vascular system. Main nutrient vessel is the thoracodorsal artery. It is originally described as the pedicle flap, later found to be much more versatile as a single stage free tissue transfer. Large amount of muscle is available for harvest, useful for very large soft tissue defect. And the versatility of the subscapular system makes this latissimus flaccid to incorporate a vascularized bone like scapula or the rib also. And the vascular pedicle has got a large vessel caliber and a length of 6 to 10 centimeter. Donor site is repaired primarily without the need of a skin graft. So this is the latissimus dorsi, and this is the thoracodorsal. It has got a transverse branch and a vertical branch, and we can use this transverse branch and the vertical branch to make the flap. So this is the flap which is being made based on the vertical branch. So this is two paddles, one based on the transverse branch and the other one on the base of the vertical branch. The uses of latissimus dorsi is mainly for large perforating defects of the oral cavity, and we can use the two skin paddle concept in the oral cavity and also in the skull base defect and also for scalp defects. We can include the rib and also the scapula, and it can make it as a osteomyocutaneous flap, and it may be used for the reconstruction of the mandible or other parts of the facial skeleton, and that will be dealt in detail in the osteomyocutaneous flap. I'm just going through the latissimus dorsi flap. And the motor innervation of the muscle is via the thoracodorsal nerve, and this nerve can be anastomosed to the facial nerve for rehabilitation of the paralyzed face and also to the hypoglossal nerve for tongue reconstruction. The disadvantage of the flap is the patient positioning. The patient needs to be in the lateral decubitus position. So, a concurrent harvesting of the flap is difficult if we are going for a head and neck resection and reconstruction. So the next
Okay.
part, this continuing part, the osteocutaneous flap and the evidences regarding the defect management and the reconstruction will be dealt. This is just an overview of the free flaps which we can use in the head and neck defect. So next Friday, I will be continuing the rest of the topic.
Okay. Thank you, Divya, for giving a good overview regarding the common free tissue transfers for head and neck defects. I think it has covered most of the aspects. You have covered the flap monitoring and general aspects and
It's a
the post-op care.
in the next class. Next class, I will be covering the osteocutaneous and the visceral flap, flap monitoring, and the evidences regarding the defect reconstruction by the free flaps, sir.
Okay, Divya, you have described so many free flaps. What are the free flaps you have seen
Sir,
doing?
I have seen the radial forearm free flap. Fibula, which I have not mentioned in the coming session, I will be using. And I have once I was in Tata, I have seen the androlateral thigh flap also, sir.
Here you have not seen.
Androlat-
So,
androlateral thigh flap. This time
okay,
I didn't see, sir. When I was
okay.
in during fellowship, I have seen one case.
So there are a lot of free tissue transfers like parascapular, lateral arm flaps, so many. But most of the defects you can manage with 3 or 4 flaps. For a
Yes,
medium-sized thin defects, radial forearm. For a larger soft tissue defects, you use anterolateral thigh. For a bony, if there's a composite defect with bone defect, you use prefibula flap. And for a continuity like pharyngeal continuity reestablishment and this you use the pre-jejunum. So most of the 3 or 4 flaps, if you know, you can manage most of the defects in the head and neck area.
yes,
So
sir.
of course there is a lot of these things like Gracilius flap, lateral arm flaps, parascapular flaps, so many perforator flaps. But with these 3 4 flaps you can manage most of the defects, and you have to wisely choose the defects, the flaps for reconstruction. There's a lot
Yes,
of options. Head and neck is area where there is a very good success rate for free flaps because of the very good vascularity, very good venous flow. So complications are usually not much in head and neck when you compare with the lower limb and all. So free tissue has a better success rate in the head and neck area. It's a favored flap, but at the same time you have other options like pedicle flaps, and you can manage most of the defects with pedicle flaps. So you have to wisely choose the defect. What is the ideal reconstructive option for a particular defect for the particular patient? So then you have to wisely choose. Okay.
yes, sir. Yes, sir.
Divya,
Yes, sir.
just one question. You had mentioned about subfacial dissection of radial forearm flap, no? What
Yes,
is the
sir.
advantage and suprafacial versus subfacial? Advantage of raising subfacial?
Sir,
No, there
actually,
should be some reason to differentiate between these two
the the
methods,
bulk,
right?
the thickness of the flap, no, sir, in
No.
suprafacial flap raising, we are restricting our dissection above the fascia, so the exposure of the tendons will be less.
Yeah.
One
That there is
aspect
a donor side mobility is the main
is
concern. The skin
concerned.
graft will be, otherwise it will be tethered to the tendons.
Tendons.
But that is a disadvantage, right? Subfacial, what is the advantage I am saying?
Sir, I don't know, sir.
Maybe it is more robust. The flap will be
Maybe the vascularity, dissection is easier, you have a better vascularity.
Yes, sir.
Then there are modifications even preserving the skin and taking the fascia alone.
Okay, sir. Okay, sir.
There are some modifications by Amrita people for a closure of the radial forearm defect by local rotation flap and all. So
Okay,
there
sir.
are a lot of things.
Okay, sir.
Okay, thank you, Divya.
Divya, I like to ask a question. Divya, other than the routine staging investigations, what investigation would you like to when you do the selection of flaps?
So the most important aspect is what tissue defect we are having, where exactly is the defect, how far is that, how much is the defect
No,
altogether.
my question is not that. You decided on for radial forearm flap. Is there any additional
What?
investigation would you like to do the viability other than Allen's test?
No, Doppler of the upper arm
You
artery, sir. Definitely we have to go for the Doppler study. So
So
that
that
all
is
sir, that I will come in the next class. That's why I
fine.
didn't go.
Fine.
No,
Yeah, fine,
I
fine,
was.
fine.
I just gave an overview. Next class, I will be giving how we have to select.
Divya, ideally you should have gone by the general principles of microvascular surgery, post-op monitoring, all those things in the first step. Then
Okay,
go to the individual flaps in the
okay,
second steps.
okay. So I thought
And
I will. Okay, sir.
and a few words about the micro technique of microvascular
Sir,
anastomosis also.
actually, I am planning to do it in the next class, and I made a.
Okay, okay,
I thought I will give an overview. Then it will be easy to go
okay,
like that. That's why, sir. Next class, I will
okay,
definitely present that, sir.
okay. Thank you.
Thank you, sir.
Thank you.